So how did the doctor tell his patient that he had diabetes? Well, he didn't sugarcoat it. What do you call it when someone rebels against their diabetes treatment? You call it insolence. Once a patient told his doctor, "Doc, you know what? The problem is that diabetes runs in my family." To this, the doctor replies, "You know why? Actually, that's because nobody runs in your family." Hi guys, Dr. Ryan here again. Thank you for joining me on our 41st Algorithm in Internal Medicine. This is our opening algorithmic approach in the discipline of endocrinology. Whoa, looking forward to this. Thank you so much for joining me. Thank you for liking and sharing my videos and subscribing to my YouTube channel. So the way we're going to approach endocrinology is in the way of opposites. What do I mean? I have 6 algorithms lined up in the way of opposites. So first up, we're talking about adrenal insufficiency, and the next one will be Cushing's. You get the idea. So the next one will be hypercalcemia, and the following one hypocalcemia. Then we're going to speak to hyperthyroidism and then end off with hypothyroidism. So let's touch base with adrenal insufficiency. This is a clinical condition that results from the deficient production or action of glucocorticoids with or without melanocorticoid or androgen deficiency. Now, clinical manifestations of chronic adrenal insufficiency include fatigue, weakness, malaise, weight loss, nausea, vomiting, hypoglycemia, loss of libido in women, orthostatic hypotension, all right, loss of axillary or pubic hair in women, and generalized hyperpigmentation of the skin and mucous membranes only in chronic primary adrenal insufficiency. All right, got that. When adrenal insufficiency is suspected clinically, an ACTH stimulation test should be performed to confirm the diagnosis. Now, the plasma ACTH level determines whether adrenal insufficiency is indeed ACTH independent, which speaks to primary disease, or whether it's ACTH dependent, speaking to centrally mediated disease. The causes of primary adrenal insufficiency can be separated into the following subcategories. We speak to autoimmune, infectious, hemorrhagic, infiltrative, and others. Now, central adrenal insufficiency occurs as a result of pituitary dysfunction, that's speaking to secondary, or hypothalamic dysfunction, speaking to tertiary. The most common causes of adrenal insufficiency include abrupt withdrawal of glucocorticoid therapy, autoimmune adrenalitis, and tuberculosis. Acute adrenal insufficiency in the way of adrenal crisis must be treated with high-dose glucocorticoids. Treatment for chronic adrenal insufficiency includes maintenance dose glucocorticoid replacement and may include melanocorticoid replacement in some patients. Let's get stuck in, guys. So the first point of departure here is ACTH independent versus ACTH dependent disease. And of ACTH independent, speaking to primary disease of the adrenal gland. First up, let's talk about autoimmune. So isolated adrenalitis, or it could be part of autoimmune polyglandular syndrome type 1 or type 2. We're going to be talking about this a bit later. Then infectious causes like TB, for instance, infiltrating the gland. Maybe it's fungal like histoplasmosis, or it could even be HIV/AIDS. Hemorrhagic in the way of coagulopathy, thrombophilia, critical illness, or trauma. All right. We're going to be talking about Waterhouse-Friderichsen syndrome, which happens when there's a hemorrhage within the adrenal gland associated with meningococcal septicemia. Infiltrative issues like malignancy, granulomatous disease, amyloidosis, hemochromatosis, and other issues like surgery, okay, radiation, medication, and the very rare genetic syndromes of adrenoleukodystrophy or adrenomyeloneuropathy, okay? So those are 18 handy ways to approach etiologies behind primary adrenal insufficiency. Speaking to ACTH-dependent disease, so this is centrally mediated, right? It's either due to pituitary dysfunction or hypothalamic dysfunction. Technically, this would be tertiary disease. This is a beautiful mid-comic from Mr. or Dr. George Muniz. Thank you so much. So here this illustrating the hypothalamic pituitary adrenal axis. And so basically we know that stress causes the hypothalamus to release corticotropin releasing hormone, which then stimulates the anterior pituitary to liberate adrenocorticotropic hormone, right? And then ACTH stimulates the release of cortisol from the adrenal cortex. Cortisol raises glucose levels and provides negative feedback. So it's just like, you know, if you're studying for an exam. So just imagine that. And the hypothalamus is saying, dudes, we have just 3 exams this week. To this, the pituitary, in the form of ACTH, says binge watching was a bad choice. And then that feeds into the adrenal cortex, which produces cortisol, which then feeds back to both the hypothalamus and pituitary, saying, will you turn your shut up? Nice one. Okay, here we're illustrating another mid-comic, Addison's disease versus primary hyperaldosteronism. So we know Addison's disease is chronic adrenal insufficiency, and the the problem here is a primary deficiency of cortisol and aldo due to atrophy of the adrenal cortex. And we see this guy when he was normal, and we see this guy when he has adrenal insufficiency. You can see how hyperpigmented he is. But remember, hyperpigmentation only speaks to primary adrenal insufficiency, not secondary. All right, and he has weakness, weight loss, hyperpigmentation. We diagnose this by ACTH stimulation, and we treat with steroid replacement therapy for life. And biochemically, what you may see is hyponatremia, and the patient may have hypotension. The hyperkalemia can accompany this, right? So hyponatremia with hyperkalemia and metabolic alkalosis, right? Primary hyperaldosteronism, on the other hand, can be due to either Con syndrome. So there's excessive secretion of aldo, which is either due to Con syndrome in the way of adrenal aldosteronoma, treatment with surgery, or bilateral adrenal hyperplasia. It could be due to there's different kinds of nodular hyperplasia in here. And you treat with spironolactone, which is a potassium-sparing diuretic. So this is opposite of this biochemical profile. So here you actually have hypokalemia with hypernatremia, hypertension, and a low plasma renin. All right. So remember that Addison's disease or adrenal insufficiency keeps bad company. So this is courtesy of Mr. Ashish or Dr. Ashish Singh over at Medicosum. Thanks so much. So type 1 versus type 2 autoimmune polyendocrine syndromes, APS. So you get type 1 is autosomal recessive, okay, and it's due to a gene mutation in the autoimmune regulator gene on chromosome 21. It entails adrenal insufficiency together with hypoparathyroidism and chronic mucocutaneous candidiasis, right? Versus type 2, which is more polygenic in terms of its genetics, and it's HLA-D3 and D4 linked. It entails primary adrenal insufficiency together with type 1 diabetes mellitus and autoimmune thyroid issues like Hashimoto's or Graves. Nice one. Okay, this is a very handy mnemonic, guys. Just to, if you want to remember the clinical features of Addison, just off the cuff, here we talk about Addison, right? Nice one. A is for autoimmune, D speaks to DIC, which is disseminated intravascular coagulation, speaking to meningococcus, and D can also stand for destruction by cancer, infection, or vascular insufficiency. I is also iatrogenic, S stands for sarcoidosis, or you can even think about lump granulomatous disease in here, like TB and histoplasmosis and so forth. O speaks to hypotension, hyponatremia, so put a misnomer there with the O, because the O is actually in the middle of the word, not at the beginning. And N speaks to Nelson syndrome, which happens post-adrenalectomy with increased ACTH production. All right, so we know those deals right there. All right, OSCE time. An 18-year-old woman reports a 6-week history of fatigue, nausea, involuntary weight loss, and darkening of the skin. Which one of the following tests is most helpful for establishing the diagnosis? Because the hyperpigmentation, yeah, even of the tongue, dudes. So you're thinking Addison, so you're going to do, you guessed it, ACTH stimulation. So worldwide, TB is the most common cause of adrenocortical failure. In first world countries, autoimmune adrenalitis and bilateral adrenal hemorrhage are the most common causes, right? Common lab findings, we've been through this: hyponatremia, hyperkalemia, fasting, hypoglycemia, anemia, eosinophil. ACTH pro-hormone production is increased, that is pro-melanocortin, which results in increased melanocyte-stimulating hormone level and hyperpigmentation. Now, hyperpigmentation is most notable on the elbows, knees, and buccal mucosa and at surgical sites. Addison's disease is diagnosed most reliably with the ACTH stimulation test. Primary adrenocortical failure is treated with high-dose glucocorticoids and mineralocorticoids. Glucocorticoid treatment should be augmented in acute illness. All right, I just want to go have a look at our beautiful algorithm one more time. I just want to encourage you guys. Helen Keller said, and I quote, let's talking about trials. She says that character cannot be developed in ease and quiet. Only through experience of trial and suffering can the soul be strengthened, ambition inspired, and success achieved. Right, so, my blueprint for living is the Bible, which I believe is the Word of God. Whoops, sorry about that. So what does the Bible say concerning trials? The book of James chapter 1 verse 2 to 5 says, "Consider it pure joy, my brothers, whenever you face trials of many kinds, because you know that the testing of your faith develops perseverance. Perseverance must finish its work so that you may be mature and complete, not lacking anything." Then he goes on to say, "If any of you lacks wisdom, he should ask God, who gives generously to all without finding fault, and it will be given to him." All right, and I have quoted this particular scripture before, but it's so powerful, I thought I would mention it again. And the book of 1 Peter chapter 1 verse 6 to 7 says, "In this you greatly rejoice, though now for a little while you may have had to suffer grief in all kinds of trials. These have come so that your faith, of greater worth than gold, which perishes even though refined by fire, may be proved genuine, and may result in praise, glory, and honor when Jesus Christ is revealed." Persevere, guys, because in perseverance through your trials you will overcome and you will develop character. All right. Thanks so much. That was our first one, endocrine. I'll see you tomorrow, where we're going to be talking about Cushing's syndrome. Oh dear. All right. See you then. Take care.